nothing but faith. There's things far too great that I want to accomplish. I'm hoping 25 hours a day, but something good works out, and I'm just like, dang. Think everything's gonna be okay. Yeah, I'm like, dang. Think you might just know the way. I'm like, dang.
Welcome to Dang.
Dang. And today we have a fantastic guest today.
Yes, we're so excited. We have Dr. Andrew Huhn with us today. He is an associate professor of psychiatry and behavioral sciences at Johns Hopkins School of Medicine. He's also the director of the Bayview Clinical Research Unit. Dr. Huhn's research focuses on understanding opioid use and opioid use disorder, or OUD, by studying what drives addiction and how to improve treatment. His work spans everything from clinical trials and brain imaging to wearable tech and stress monitoring. He's especially interested in factors like sleep, cravings, and mood, and how they impact recovery. His ultimate goal, to find better ways to treat addiction and make healthcare work smarter for people struggling with substance use disorders. Welcome, Dr.
Welcome,
Huhn.
Dr. Huhn. Thank you so much for being here.
Thank you for having me.
Great. And the first question I have for you is, what sparked your interest in the study of opiates and addiction?
Yeah, I think that that has several answers.
Okay.
So I have quite a bit of addiction in my family, and also in just folks that I grew up with, family, friends, etc. So kind of seeing them struggle, and often feeling baffled by the kind of revolving door with treatment and how difficult it seemed to be to stop using. I think when I was in college, I actually volunteered at a hospital-based detox, one of these like 3 to 5 day programs.
Oh, yeah.
I thought it was a hot mess. I wanted nothing. I wanted nothing to do with it. And later, when I was working on my Ph.D. in neuroscience, I got kind of reintroduced to the addiction topic, and I thought, you know what, if anything, there's an area of opportunity here. And so I like problem solving, and I like working with these folks, and it's personally important to me, but also scientifically interesting.
That's great.
So what was it, when you say it was a hot mess, I'm curious. What was it like? Is that what you're gonna...
I was going to say something else. I definitely understand what you're talking about, because I went to 3 or 4 different rehab facilities before I got sober, and most of them were hot messes. They were just terrible. They didn't really care about the patients. They didn't really... All they really wanted was your insurance money, is what they really wanted. They really didn't care much about you. It wasn't until I went to the last one where I got sober, where they really cared about me, and they wanted to find the underlying issue of why I was using. And one of the things that helped me was they started treating me with Depakote. So it gave me, because my reactions was so fast to things, I didn't never time to think about it. They said that my brain had stopped producing sulfuric acid. So when they started me on Depakote, it gave me the first real chance to get sober, and I stayed sober since then.
Yeah. Yeah, no, I mean, that's definitely part of it. Like, we offering comprehensive care? Are we thinking about all of the other things that make up life other than just the actual drug use? And that's what, when I say I thought it was a hot mess, it was because we would get people in. It was like a 3-day, inpatient type of thing. They're not even done shaking, and they're back out on the street, and it just felt like, it didn't feel like high quality. Yeah, exactly.
But those 3 to 5 days, a lot of those companies make a good amount of money, and they put them out there, and then they know it's gonna be a revolving door for them, and they'll get them back, in a time frame that they're allowed to, and they bring them right back in.
Yeah, there's definitely some pockets, I think, in the U.S. that are really bad offenders with this kind of thing, and but it also speaks to maybe a broader issue that addiction treatment developed apart from mainstream medicine for decades.
Yes.
Because it wasn't really seen as something that was like a medical condition per se. And because of that, we have these, standalone kind of treatment facilities. Everybody has their own idea of what care is, and, but a lot of places aren't offering any kind of real medical care. It just becomes a kind of drop off your person who's hit rock bottom, and we'll keep them for 30 days and then, back out they go. We'll see you in a few months.
Yeah.
That was like the model of care for a lot of these
Oh,
places.
yeah.
Right.
Yeah.
So
Very-
kind of what he's saying is that like I just trying to understand because I'm a newer person to this sort of industry and this environment, learning about it through a lot of Todd's experiences. And so what you're kind of saying is that it was the whole field of addiction recovery was one that was kind of treated not as a medical condition.
No, that's
And
what I was going to say.
Yeah.
When I first got in the program, it was not widely, it was not accepted. It was shamed upon if you did that.
Yeah.
It was like, you got treated lower than low. You were considered the lowest person in the world if you had to get sober or you were doing something like that. It was not treated as a medical condition at all. And it's like in today's world, they applaud you for getting sober. They applaud you for going to treatment. It wasn't
So
like
we've
that.
made
It was terrible.
we made some good progress. What about as far as the studying and the advancing of the field,
Yeah.
Dr. Huhn, when did that start to transform, to be recognized as medical?
Yeah, I think really since the turn of the century, so since around the year 2000, that's when the opioid crisis really started to kick up, and people, I think the overdose deaths that affected, it wasn't just relegated to urban communities anymore. It was hitting rural communities and suburban communities, and everybody kind of started to understand that this is a bigger issue, and which again kind of speaks to some historical biases,
Yeah.
like, well, if it's in the inner city, then we don't care about it, kind of thing.
That's
And
right.
now there's I think they've made great strides in the last 20 years.
Yeah, that was another thing I was going to say is when it mainly affected, like when crack use was big, it mainly affected the inner city. And
Yep.
the sad part about it was they saw crack use and cocaine use as two different things, and it's not. It's the same thing.
Yeah.
But they saw it as two different things. If you were on crack, you were lower than low. If you were doing
Yep.
cocaine, you just had a little problem. So
Why do you think that was?
Well, because can you tell us why you think it was, Dr. Huhn?
Well, I think cocaine was more socially acceptable and
Yeah.
the kind of part scene,
Mhm.
not so uncommon that if you're out at the bars drinking, something like that, you go to some after party and people are doing cocaine. Crack was seen more as a kind of street drug, something for people who are homeless or hard up or something like that. There is really not. I mean, it is the same drug. It's just different routes of
Yeah.
administration.
Yeah.
It's not like snorting something is so much better than
Yeah,
smoking.
exactly. Yeah.
Yeah.
So what was that like, Dr. Huhn, coming into this field? You said that you kind of saw, you were brought back to it and you said, well, there is definitely opportunity for improvement here. What was that like to begin in that?
Yeah, it was really interesting. So the first kind of big study that I worked on was focused on people with prescription opioid use disorder. This was like in the early 2000s when that was really
Yeah.
the main dish, and since then it's become heroin and now fentanyl.
Yeah.
So it was focused on that. It was focused on predictive modeling of treatment outcomes. So basically, we were trying to look for objective and subjective factors during residential treatment that would predict if people were going to relapse or not in the first 3 months after treatment. And I just learned a lot during that study. There was a neuroimaging component, there was a sleep monitoring component, there was a stress monitoring component. And so I've been able to take that initial study and kind of grow out my research program in several directions from that.
And when you say that a lot of doctors were just like prescribing it as a Band-Aid, you know what I mean? That was happening a lot too, right? Like a lot of doctors were just like, my knee hurts. Oh, you take this.
Yeah, way over prescribing. You're getting these kind of massive prescriptions for oxycodone or whatever after a surgery, not necessary. And I think the rationale was like, well, if I give them a whole bunch, they shouldn't come back. And if they do come back, then I can say they have a problem and they need to see somebody else. But because of that, you get all these extra opioids on the street. And then there's these also in the early 2000s to kind of 2010, 2013 area, these what I would call pill mill kind of pain clinics where anybody could show up, say that they have pain and get put on a script for an opioid like oxycodone.
Now, let me ask you another question. What do you think, how has this hurt the person that does need it? How has this hurt them? The rules that they've made.
Yes, yes, the pendulum doth swing, right?
Yeah.
Yeah.
So then now I don't know if we're over, I think we're over restrictive in some ways, but right, like opioids actually are a very good painkiller and are totally, necessary and appropriate in many situations. But what happens when it goes so far one way is that when it comes back the other way, now we're getting in a situation where, sometimes we're being too limiting with people. And especially, I mean, a big initial push that you saw in like around 2012,
Hmm.
2013, when the DEA started to crack down on these quote unquote pill mills,
Hmm.
those people are all physically dependent on opioids. So when you cut them off, they need to go find it somewhere else. And that's where the heroin boom kind of started.
Oh, okay.
And you still see that today. I mean, you still see people who are being, who have chronic pain, have a legit reason to be on an opioid prescription and are trying to be tapered or something like that, and then they're out finding it on the street.
So, opiate use disorder can be such a complex topic. How would you explain what happens in the brain during an addiction in a way that makes sense for someone outside the medical field?
Yeah. So kind of two things happen um, early on. Well, and it's a common theme throughout. So drugs of abuse, so any drug, alcohol, can kind of hijack your brain's pleasure centers, for lack of a better term. So you get a lot of, you get a big high from using the drug. It feels good at first. For some people, it feels better than, other kind of natural rewards like food or sex or exercise. But over time, you just can't get there anymore with the drug. So the drug kind of starts to downregulate that pleasure center. Now you're not getting the same pleasure from the drug, and you're definitely not getting the same pleasure from things that should be naturally rewarding.
Yeah.
So this just starts to go down and down over time. At the same time, early on, the drug use probably relieves stress, right? Like a
Hmm.
lot of us, you have a hard week at work, you go out with your friends to the bar, you tie one on, you blow off some steam, that kind of thing. But again, as your kind of reward center is decreasing in its ability, your stress center is kicking up. And so you'll start to have, kind of unreasonable stress response to minor things. So we talk a lot about stress reactivity. We talk about kind of daily um, stress that is, can fluctuate up and down throughout the day. Um, it's kind of, you can think of it as like pleasure versus stress. And more and more it becomes about relieving stress that is caused by the addiction rather than about getting high. So somebody who you see who's very far progressed in their opioid use disorder, physically dependent, all the social functioning is gone, et cetera. Like they are using to relieve stress at that point. Like they're not getting very high off the drug anymore.
Interesting. I didn't kind of realize that relationship where it became less even about like they're not even enjoying this anymore. It's more just
Yeah.
Where
yeah,
you're chasing,
Just get back to
a
normal.
high.
a relief.
Yeah, some
Yeah.
people do that
So
a
it
lot,
becomes
yeah.
just more about relief
Yeah.
than interesting.
Yeah, they're getting normal. They're not getting high.
Yeah.
Yeah. In your studies, you worked closely with people struggling with addiction. Are there any stories or things that you've personally observed that really struck you over the years?
Yeah, I mean, many. It's interesting to be a clinical scientist. So I'm a neuroscientist by training. I'm
Hmm.
not a physician, but I run clinical trials. So when I see patients, it's always in the context of a scientific study. And for that reason, I have to be objective, right? Because we want
Hmm.
the science to be good, but
Yeah.
also I'm not like some cold-hearted guy. Like we do
Yeah.
work with people. We ultimately, like, once the study's over, I want the best for them. So we're trying to work with them constantly to get, in long-term care and get their life kind of straightened out. So, we've had several wins, people who have come through our trials who we'll see again later and they're still doing well, and that feels really good. But then we also have people who, keep coming back trial after trial and, they keep trying, but it's just not sticking.
Yeah.
Yeah, I've always found that when, like in the beginning for addiction, it has such a negative effect on some people. And I think today more people are affected by it. So it's changed a lot of people's views. You know what I mean? Because now, like you said, it's in every community. So everyone's being hit by it. they know someone or it's directly connected to them. So the perception has gone down, you know. But I think they still don't understand that, you know, this is not something that people, you know, set out to do. No one sets out to do it, you know. And I think like in your case, you've worked through these studies. Have you found that people have some really sad stories behind this, why they ended up the way they are?
A lot of trauma. Yeah, a lot of trauma, especially in the women with opioid use disorder. So, you know, we often, as part of our studies, we're doing kind of in-depth clinical interviews, and the trauma question comes up. And so, yeah, we hear quite a bit about that. There's also just like the daily trauma, you know, things that might be traumatic to you or I if we experienced it, but these folks are like seeing this stuff all the time, especially if they're, you know, like I'm in Baltimore City, so you know, people using drugs in Baltimore City. If you're in the city, you know, you're exposed to a lot,
Yeah.
and I think
Yeah.
it's really hard to quit. I think it would be easier if you were in an area where drugs weren't pushed in your face all the time,
Yes.
and so that's part of the problem.
Yeah.
So I recently read Matthew Perry's biography,
yeah.
and I think his story is one that is really eye-opening and really tragic, honestly. What struck me kind of as a takeaway from that was how this chemical, this opiate addiction is so difficult to treat, just because he was talking about how he's literally, you know, because of the extensive use periods, that he'd altered his brain so much that it was like to be just normal and have nothing, it was like not even possible anymore. But that some of the treatments, like literally in rehab that he would be given, like becoming addicted to those, like it just seems like such a perplexing problem. And I'm really intrigued from your perspective.
He was given
Dr. Huhn.
ketamine, right? So can you tell us the difference
Well-
between ketamine and opiate? Is it the same thing as opiates?
Are you familiar with his
Yeah.
story at all? I don't know.
Yeah, I'm somewhat familiar. I'm not.
Are you familiar with ketamine? You are?
Yeah.
Okay,
yeah.
what's the difference between ketamine and opiates?
So ketamine was probably being used therapeutically to treat mental health.
Okay.
Like, so there is a body of literature that shows that it can work as an antidepressant if you're taking it like once a week, once every other week, something like that. Not every day. I don't know anybody who recommends taking ketamine.
Taking
Yeah,
it every
taking it
day,
every day.
right?
Like a maintenance every day kind of thing.
Yeah.
Ketamine is a funny drug. It is, it's what I would call a promiscuous drug. I say that because it hits a lot of different types of neurotransmitter systems in the brain. So it does hit opioid receptors, but it's not considered an opioid. So it's also it's used in anesthesia. You can actually perform surgery on ketamine alone.
Wow.
Rather than like if you were to use fentanyl or morphine, you would need another drug to keep you unconscious, and you would need another drug to keep your muscles relaxed.
Wow.
But ketamine does all of the above.
Wow.
So, yeah. So it's a special one. But yeah, I'm sorry. What was
Well, I kind of wanted you to speak to that idea that how does this work is once they've kind of gone down that pathway for so long and their bodies are dependent on this chemical, how do we handle that? How do we treat that?
Yeah, so there's kind of two main avenues, right? You're going to go on a maintenance medication like methadone or Suboxone. And these are either full or partial opioid agonists. That means they act on the same receptor. They just hang out there all day. So instead of the kind of, you know, if you're somebody who uses recreationally, whatever, you're experiencing this big up and down in opioid levels in your body. And so that's not the case for those folks. They just get maintained. And that's one way to go about treatment. The other way is that you're going to have to, if you're not going to do that, you're going to have to go through opioid withdrawal, right? Like there's there's no way around it. And that's very tricky to treat. It is, we can treat it, but it can be a little bit complicated. It can be very uncomfortable for the person if they're not, you know, if they're trying to do cold turkey or something like that. I would say you have little to no chance of making it through opioid withdrawal cold turkey. Maybe you can, you know, very, very small chance though. But even like you get through the acute withdrawal symptom, which feels like something of a mix between like the flu a depressive episode and intermittent panic attacks, something like if you can imagine those three things
Yeah.
occurring at the same time, that would be about what opioid withdrawal can feel like.
What do you do? Like if they were to seek professional help, what is that going to look like? What happens? How do they support somebody through those symptoms?
So yeah, that becomes like a residential or inpatient thing. You can do it outpatient, but you just have such a high risk again of like going off the recommendation. So typically it's done residential or inpatient. They would typically use an opioid to taper you down. So just giving you smaller doses, you know, over a few days. It could be over a few weeks if you're really struggling. And then there's just other medications that kind of hit other neurotransmitter systems that are involved in opioid withdrawal that we can use to kind of, I think of it like playing whack-a-mole, you know, at the arcade. Symptom pops up and we whack it down, and we just keep doing that until
so the person, like I even talking about, Todd talks about having to be restrained at some points. Is being restrained a typical part of treatment?
No.
No, I was restrained because I was out of control.
I know. I'm seriously curious. I'm like, what does this look like? Well, right? Like, if I've never been in a treatment facility watching like treatment happen. What does it look like?
If you're the reason why I was restrained, let me clarify that so you understand.
Okay.
The reason why I was restrained because I was threatening staff. I had been on about a 2-year run. Yeah. And they tried to wake me up to go to a meeting. And that was like not happening for me emotionally at that point. I hadn't slept in weeks. So, you know, that's why. So they restrained me. But in that restraining of me is where I found God, and I found the key to getting sober. Yeah. God told me what to do, and that's how I got sober.
I didn't mean it as an insult.
No, I'm just saying that's why. It wasn't like I just went in there, you know, and they restrained me. This treatment didn't restrain me.
I just don't know how it works, and I'm super curious, and I know there's a lot of people that are curious.
Gave me shock therapy.
Yeah, like
you'll get this done.
No, it's crazy if you read about some of the treatments that have done in the past. Like I don't know what had brought me down the rabbit hole, but I was learning about like the lobotomies and things that they used to do to treat certain.
Oh yeah.
I mean, there's some crazy stuff that. Yeah. So what
this is you were two separate things, but this
I know that's not addiction. That's
exactly why, you know, people went to AA meetings, went to 12-step programs, went outside of the medical community to get treatment because the things the medical community was doing back then,
it was too dangerous.
Were not helpful. Were hurtful.
And also for me, when I got sober, I steered away from CA, you know, those things programs because they were so new. Mm-hmm. It was actually AA is where I got sober, AA, because it was such a longevity in there. And, you know, but they didn't let us say that we were alcoholic addicts in the beginning. They did not. They were not okay with that. You know what I mean? But we just kept doing it anyway. We were defiant. We're like, we're going to do it anyway, tell you who we are. And then now it's very accepted everywhere now. They get it. It's the same thing, you know?
Yeah. Yeah, definitely if you can get in a group that has quality long-term sobriety and you can learn from that, I think that's incredibly helpful. Oh, yeah. But also to the point about Todd's experience with withdrawal, I mean, that's not totally uncommon that people get extremely agitated during that process. And especially, so this is actually what brought me to researching sleep in the context of recovery. It's just what Todd said. It's like, I know, like when we have people in a trial, if they don't sleep for a night, 2 nights in a row, they're on, like they are going to be out of there.
Yeah.
So there's a lot of, I think as we get better at treating the withdrawal condition and, you know, and other aspects of addiction, you're going to have less and less of those. It just makes it easier for people. It makes it should feel, you know, it should feel good to get into recovery. It should, you start to feel function return to your life. You should start to feel happy again. You should, you know, you should go for a walk by the river and feel good about that kind of thing.
Sort of like retraining those receptors, I guess, a little bit.
Yeah.
But can you tell us more about what it's like? Maybe not Todd's experience being typical, but what is that like? If somebody, when you check into a treatment center, what is for you or your loved one, what's it going to be like for the next little bit?
Yeah. So kind of, I would say that addiction treatment in the U.S. is a choose your own adventure book. So the first step is figuring out where you're going to engage the treatment community, right? So if you do the kind of typical thing that you would see in the movies or in TV and what people do, you know, you show up to a residential facility, they'll generally keep you for between 1 and 4 weeks, something like that. During that time, they should be figuring out the medication situation, like what mental health issues are going on. What medication support do you need long term? What do you need short term, and then what do you need long term? They should be figuring that out. I don't think they all focus on that very well or even address it. After that, you could expect to be in kind of regular outpatient therapy. Should be for at least 3 months, but probably more like a year or more. And a lot of people choose to do 12-step meetings, which I think are incredibly helpful. That can be a daily thing. That can be a twice weekly thing. You kind of figure out the intensity of that as you go. So that's like one pathway, right? Another pathway is that you just go to outpatient directly. And there's a lot of reasons that's the most common pathway, because not everybody has money for a residential facility. They don't always have space. If you go the outpatient route, that could look, it could be an intensive outpatient program where you're going several times a week for several hours out of the day, and then that kind of tapers off, or it could just be a straight up outpatient where you're seeing a counselor once or twice a week.
And the idea being that when they're doing this outpatient, that when they're not at treatment, they're at home. Are they just sleeping? Are they just chill?
Well,
like what?
They're supposed to be doing the 12-step program, but the problem is when addicts get in their car, if they don't have proper guidance and they're not in a facility, that your brain will go on automatic pilot and drive you to a dealer's house. That's just what happens. It's pretty fast. Can you explain to us dual diagnosis and what people have in this dual diagnosis? Explain what that is.
Yeah, so that just means that there's another major mental health condition that goes along with the substance use disorder. Often it is, a point of origin for the substance use disorder. Like you have really bad anxiety, generalized anxiety disorder, and it's, pretty rough on you. You have a really hard time in social situations, and you discover in your teenage years or early adult years that if you have a drink, take a pill, do something before you go into these social situations, you perform better, and then it just spirals from there.
With that definition, is there really any addicts that don't have a dual diagnosis, or is it?
Well, sometimes they just have a set of life circumstances, and nothing really qualifies for a diagnosis.
Yeah.
Okay.
Doesn't mean you don't have to have a diagnosis to have poor mental health, or to be suffering, and have symptoms. And so that's kind of something that I've adopted quite a bit in my own research, is that, I mean, we do the diagnostic stuff, but then we are tracking like emotions, thought patterns, cravings, etc. We try to do it like several times a day, over a week, over a month, something like that, so that we can really start to see how these patterns of mood and craving, etc., are affecting you on a day-to-day basis. So we are, I think we're more advanced now than we used to be in that regard.
Good. That's good.
Yeah, that was actually one of my other questions, is kind of where are we at? How would you grade our progress? Like if this epidemic is, we're kind of 20 plus years into it, and we've obviously made some strides. Where do you think we're at? And kind of, we were talking about earlier, the pendulum as it swung, what do you how would you kind of grade our progress?
Yeah, I think they've made great progress in a few areas. I think some of the harm reduction initiatives have been really helpful, getting naloxone, accessible to people, helping kind of educate people, understand, best quote unquote or safest practice for if they are going to use. Another thing that's been really helpful in the opioid field is expanding buprenorphine and methadone. Those are just easy, easy access outpatient kind of treatment that if you want to get clean today or tomorrow, you can go into one of these clinics and get started. So that expansion has been really helpful. What I would like to see more of is the kind of support, social support, behavioral health support, especially for some of these people who are on medications. Some of those folks, they just want to be on the medication and they're just going to live their life on the medication, and that's fine.
Like that pathway number one you had described above, where you get these, the methadone or whatnot, and then some people just want that.
Yep. Some people just want that. Some people want that. Plus they want to, really work on themselves too. And that's, I think, where I see the next area of opportunity. It's so on one hand, what I think we've been good about is kind of increasing access to care for the folks with opioid use disorder. What I'd like to see us get better at is optimizing care. So how do we maximize the outcome for somebody? You know, are we doing enough to help these people? And my idea there is that if, you know, drug use isn't really about drug use. It's not
right.
it's not so much about like the act of using the drug. It's about a whole bunch of other stuff that makes up who you are and, you know, your life quality. And so what can we do for all these other things? You know, can we help people improve their sleep, their exercise, their family relationships, their mood? You know, can we address the diagnoses like mental health conditions, chronic pain conditions? And if we can fix those things, you know, shouldn't the drug use take care of itself? Like, shouldn't we be able to help people be the best that they can be? That's kind of where I'm at with my stuff.
Okay, and we have one more question. Okay, if you could change one thing with opioid disorder treatment, what would that be?
Only one?
Okay, you can give us two. Give us two.
I would, I would increase the intensity and length of treatment on average. I think people don't get enough support early on, and they tend to drop out of treatment early. And so I would like to really see an approach where it's like, we're in this for life. You come and you need help. We want you to be healthy for life.
That's
and
good.
Take that approach. I think that could be my one thing. That could.
Yeah, to me, that's definitely is how I see it. Some of these programs, like you said, they get you in a couple of days and you're out. And, you know, to me, there's no way that person's going to survive if they don't stay in treatment for, you know, my thing is mandatory 30 days and then 60 days. And then what I did was I stayed in the program for 35 days and then I moved to a sober living, but it was a whole community of sober living. And in that sober living, you had to go to 4 meetings a day. You had to have breakfast together. You had to do everything together. And it really taught me it taught me again that I wanted to be sober and how to stay sober. And at that point, you know, and it was interesting because I was voted most likely not to stay sober. But but out of 5,000 people, I'm the only one who stayed sober. Because I got the F's, the F-its is what I got. To the point where I was like, you know something, I'm gonna stay sober just to spite you. Yeah. You know what I mean? And then I caught the miracle. You know what I mean? And that's what usually happens. I stayed in long enough to where, you know, I was so headstrong that, you know, I caught the miracle. And I was like, wow, this is great.
You know, I do have one more question for you, Dr. Huhn, if you don't mind. We've actually encountered some of this too firsthand where they have done, I've been impressed at the tracking systems on, you know, prescription opiates and some of the things that we've encountered. Todd recently had a shoulder surgery. So, but how do you think current policies are balancing this opiate epidemic with the need of people that have legitimate pain so that we're not inadvertently driving people back to the streets?
Right. So I do think there's some technologies that are available to us now that are not being used widely. You know, there's simple things like pill dispensers that I've used them in my trials. It can be accessed through an app. You can collect a little bit of data while you're at it. You can get their pain level, you can get their mood level, whatever. And then through the app, it's dispensing the pill out of like a secure dispenser. That way people can't overdo it. You know, should prevent overdose, should be a means to track it. It's not that expensive, but somebody does have to pay for it. And typically insurers aren't willing to pay for it. There's also abuse deterrent formulations of some opioids that are on patent. So your insurer doesn't want to pay for those either. They would rather pay for the generic, you know, not abuse deterrent.
Yeah, so it's inexpensive. So they're just like, let's just give them the full strain.
Yeah, I mean, so much of, you know, what I think some of the ideas and stuff that spin out of academia just hits reality with the insurance industry and what they're willing to.
The thing that happened in New York definitely hit that. You know, the shooting in New York, and it made a lot of insurance companies start okaying a lot of stuff. You know, I mean,
I don't know what. Well, no,
I even read that they denied a girl throw up. She was having getting chemo, and they denied her the anti-nausea medication.
Yeah.
I mean, that's sad when it's, I mean, so I think that couple around, if we work together long enough with these people, like what you're doing, and to get everything moving forward, we can really help the people on the planet. But
That's got to be frustrating, Dr. Huhn, to see ideas that get hard-earned kind of in research then confront the marketplace.
Yeah, we run trials and it works and it's successful, and then I mean, you have to think about the problem all the way through. So I try to do this with my own stuff. Like I think about the end product at the beginning. Like when I'm thinking about a research topic to design a study, I'm already thinking about what's my end goal. Like, is the end goal that I'm going to publish a paper? Is the end goal that I'm going to change, some practice? And set yourself up. This is a message to fellow scientists. Set yourself up for success right off the bat. Design research that is going to be impactful. But yeah, I mean, some of the things you can't control, right? I mean, the insurance stuff, it was different in the year 2000 than it was in the year 2012, and it's different now than it was in the year 2012. So
I just think the more people they can get to stay sober, the less money the insurance has to spend. I truly believe that.
Try to make that argument. Yeah,
I do believe that.
Well,
and the less people that'll be breaking, less people that'll be breaking in your house. It's the same thing.
Yeah, keep them out of the emergency department.
Exactly.
I mean, you know how expensive it is to go to the emergency department.
Yep.
You want to save $20 here and then spend $30,000 there.
Exactly. Yep, you're right.
I know.
You have any more questions, honey?
No, I think this has been great, Dr. Huhn. Thank you
so much, Dr. Huhn, for being on with us.
Yeah. Oh, it's my pleasure. Thanks for inviting me.
Oh, you got it. And
do you want to say dang?
Dang.
I love it.
Well, dang. Thank you for coming. We really appreciate it, Dr. Huhn. Thank you so much. And that'll be our current episode of Dang today. And what
I think it's about time we get to is the prison episode. People want to
I never went to prison.
Hear about your experience in prison. So if you have questions about what it was like for Todd in prison, or what it's like in prison, you got to write in. Go to dangpodcast.com. Share your questions. We're going to do that episode.
Yeah, because I will tell you what it was like to be next to Richie Ramirez, the Night Stalker, and Eric and Lyle Menendez. I will tell you all the stories that I had in there and what it was like.
All right. Perfect. Thanks so much.
Bye-bye.
See you next week.
This podcast is produced by my wife, Betty Jo Bridges, in collaboration with Pop Populi, and edited by our daughter, Adelie Ann.
She is also the musician responsible for our theme music, so go check out Adelie Ann wherever you stream your music. Have a question or topic you want us to cover? Send us your suggestions at dangpodcast.com.
If you would do me a quick favor, please subscribe or rate our podcast to make it easier for others to find. Have a great week.
I'm running on nothing but faith. There's things far too great that I want to accomplish.